I'll go ahead and call our meeting to order of the February 25th Benefits Insurance Committee meeting. At this point in time, Ms. Thompson, if you would, please call the roll.
Preble Acton. Rhonda Allen. Rhonda Allen. Dr. Andrea Anthony. Dr. Andrea Anthony. Doug Bodery.
Here.
Amber Brown.
Here.
Shay Crowell. Shay Crowell. Holly Deering. Holly Deering. Alan Farley.
Here.
Mary Hickerson.
Here.
Lois Miller.
Here.
Alan McAdoo. Jeff Phillips. Jeff Phillips. Shantae Sherrill. Shantae Sherrill. Eric Tutobeni. Eric Tutobeni.
That's only 5.
Don't have a quorum.
I think Holly Deering's coming. Can you read it again?
I see Shantae. Did you have her?
Shantae.
I'm pretty sure I see her on the monitor.
We appear to, some may have missed roll call. If your name was not called at roll call, would you let us know that you're present so we can determine a quorum? Shantae, are you on? Shantae?
Mr. Chairman, this is Commissioner Allen. I'm on.
Okay, Commissioner Allen.
Shay Crowell is on. Holly Deering is on.
3 more. We do have a quorum. Thank you for
Did you
speaking.
get Holly Deering?
Okay, thank you. Chairman detects a quorum.
Mr. Chairman, I see Shantae. I just think she's having some
Yeah, I
technical
think
difficulty.
Shantae is on. Probably just doesn't have a mic on, but we see you. So we're
Holly Deering is on.
Holly Deering. There, we got you. So we're gonna count Shantae because I see her. So let me read the opening statement for our electronic meeting determination. This meeting is the Benefits Insurance Committee meeting is being conducted electronically pursuant to Governor Bill Lee's Executive Order 16. I would ask that for a motion that conducting the meeting electronically is necessary to protect the public health, safety, and welfare in light of the coronavirus. Is there a motion? Do I hear a motion?
Chairman.
If you would, just identify who makes the motion.
I can't hear them. Okay.
Who made the motion?
You walk up to my Zoom meeting, Ben. Karen's got the door. Oh, okay.
Mary, did you make the motion?
I'll make the motion to approve.
All right, I have a motion from Mary Hickerson. Is there a second? I saw Lois's lips move. I guess that's a second, right?
Yes.
Okay, I got a second. All right.
Alan Farley.
Huh?
Alan Farley just came on too.
Alan Farley, second also. If you would, Ms. Thompson, please call the roll.
Preble Acton.
Put it on my picture.
Rhonda Allen.
There.
Yes.
On the top.
Dr. Andrea Anthony. Dr. Andrea Anthony. Doug Bodery.
Yes.
Amber Brown.
Yes.
Shay Crowell.
Yes.
Sorry.
Holly Deering.
I'm sorry, I'm not writing something.
Yes.
Okay.
Alan Farley.
Can't hear them.
Yes.
Mary Hickerson.
Yes.
Lois Miller.
Yes.
What, which one?
Alan McAdoo. Jeff Phillips. Jeff Phillips. Shantae Sherrill.
Present. I'm sorry, I'm just not getting, I'm sorry. But yes.
Thank you. Eric Tutobeni.
All right, thank you, Ms. Thompson. Next on the agenda is approval of the minutes that were sent to you electronically. Is there a motion to accept the minutes?
Motion to accept, Holly Deering.
Have a motion to accept the minutes as approved. Holly Deary, is there a
Shay
second?
Crowell, second.
And a second. Call the roll, Madam.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Doug Bodery.
Yes.
Amber Brown.
Yes.
Shay Crowell.
Yes.
Holly Deering.
Yes.
Alan Farley.
Yes.
Mary Hickerson.
Yes.
Lois Miller.
Yes.
Jeff Phillips. Shantae Sherrill.
Yes.
Eric Tutobeni.
Thank you, Madam Clerk. Motion passes. Item number 2 on the agenda is financials. Director Elam, you're recognized.
Thank you, Chairman Ketron. For the 264 fund, month of January 2021, revenue is $7,705,586. Expenditures was $6,117,022, and with a positive revenue over expenditures of $1,588,564. Your calendar year-to-date numbers will be the same, since this is the month of January. Total enrollments, we had 6,326. And for the fiscal year-to-date numbers, $43,037,173 in revenue. In expenditures, $49,899,355. And you're showing expenses over revenues, a negative $6,862,183. That's for the 264 fund. The 266 fund for the fiscal year 2020-2021, for the month of January, you had in workers' comp, you had $1,022.36. For OJI, you had $26,950.72. And for the month of January, it was $27,973.08. Your year-to-date totals for workers' comp is $49,410.30. OJI is $304,847.30, and your year-to-date total is $354,257.60. Mr. Chairman, that concludes my report.
Thank you, Mr. Elam. Is there a motion to accept the financial report?
This is Lois. I move to approve it.
Ms. Miller on the motion for approval. Is there a second?
I'll second it. This is Jeff Phillips.
Jeff Phillips on the second. Call the roll, Ms. Thompson.
Rhonda Allen.
Yes.
Dr. Andrea Anthony. Doug Bodery.
Yes.
Amber Brown.
Yes.
Shay Crowell.
Yes.
Holly Deering.
Yes.
Alan Farley.
Yes.
Mary Hickerson.
Yes.
Lois Miller.
Yes.
Jeff Phillips.
Yes.
Shantae Sherrill,
Yes.
Eric Tutobeni.
Thank you, Madam Clerk. Next, we have the Workers' Comp OJI. Mr. Good, you're recognized in the well. Good afternoon.
I'd like to report in the month of January that we had a total of 18 injuries requiring medical attention. Since January is the first month for the OSHA calendar year, that's also the total for the year to date. Of those 18, 12 were OSHA recordables, and they broke down with 9 of them being restricted days. 1 was a lost time day, and 2 were all others. As you look at the next page of your graph, you'll notice that in 2019, in the month of January, we had a total of 13 injuries. Last year in 2020, we had a total of 26 as compared to the 18 for this year. Next page of your report, you'll see that the incurred dollars in 2019 were $22,000 compared to 2020 at $76,000, and this year, $72,000. On the last page of the report, we broke down the injuries by the different divisions. The Board of Education had 8, and the County General had 10. The Highway Department did not have any in the month. Of the 10 in the county, they were basically across the county area with the Sheriff Department, Paul's, Fire and Rescue, the County Clerk's Office, and the Health Department were where those 10 were located. And that's my report at this time, sir.
Okay, thank you. Any questions or any questions for Mr. Good? Seeing none.
I'll move to approve the report, Mr.
I have a
Chairman.
motion to approve the report from Commissioner Phillips. Is there a second?
Second from Mary.
Second from Mary Hickerson. Call the roll. Ms. Thompson.
Rhonda Allen,
Yes.
Dr. Andrea Anthony, Doug Bodery,
Yes.
Amber Brown,
Yes.
Shay Crowell,
Yes.
Holly Deering,
Yes.
Alan Farley,
Yes.
Mary Hickerson,
Yes.
Lois Miller,
Yes.
Jeff Phillips,
Yes.
Shantae Sherrill,
Yes.
Eric Tutobeni.
Motion passes. Thank you, Dan.
Thank you very much, sir.
Yes, sir. Next, we have item number 4, the wellness update. Mr. Chapa, Cigna Wellness Coordinator.
Thank you, sir. Can you hear me okay?
Yes, sir.
Alrighty, so the numbers continue to look great for the incentives for February. If you take a look there, for annual physicals, currently year-to-date since October 1st, we're sitting at 638 versus 509 this time last year. For biometric screenings, we're sitting at 1,152 versus 937. Health assessments are at 345 versus 246. Mammograms are at 435 versus 393. OBGYN screenings are at 581 versus 560. Colon cancer screens are the only one that we're down by just a little bit, 147 versus 182. Cervical cancer screens were at 584 versus 478. Prostate exam screens were at 180 versus 155. Flu shots were sitting at 1,874 versus 1,818. The new goals that we have added, work with a health coach to achieve a health goal. We've had 7 individuals complete that goal. We've also had 5 people complete the work with a health coach to overcome a chronic health problem. And then we've had 3 individuals complete the 16 weeks of the Amata Diabetes Prevention Program. So that puts us currently as 1,073 individuals complete for their goal versus 822 last year. So we're pretty much up across the board with the exception of colon cancer screens. Excuse me. And we actually have a plan. We're going to try to do a couple programs and events going in later into the year to help increase and improve those numbers. So we do have a strategy to help with those. Going into current and upcoming events, so we do have the mobile mammography bus scheduled. We have got that ironed out, so we'll be communicating that as soon as we get closer to those dates. Our annual physical month and biometric screening event for that week last week, unfortunately due to weather, we had to reschedule those. We've had several of those individuals be able to get rescheduled, and then we are pivoting to provide a secondary event and program for Q2 to be able to get those additional things. So we're working through that right now. And then again, Wellness on Wheels, we're ironing out the final details on those, and that will conclude what I have for my report.
Good report. Thank you so much, Mr. Chapa.
Thank you.
Item number 5, MedPoint report. Clinic Director, Ms. O'Neill.
Hello, can you hear me?
Yes, ma'am.
All righty. So we're going to start with our visit analysis. You'll see that in the month of January, the centers had 617 visits. Of that, 441 were unique members seen.
Just picking everything up.
And 34 visits in January were nurse visits.
In here.
I will say to go along with that, that January traditionally is a lower volume month in healthcare across all of our clinics. And with those visits, 251 of them were at New Salem, 172.
That's to be a little bit since I'm late.
194 at Walter Hill. For the unique member types by health center in January, 73 of the visits were by children, 467 by employees, and 77 of them were staff members. 121 members had more than one visit in the month of January. One member had 9 visits. That one was a little bit unusual, but that person had COVID, and so we're getting some follow-up care for some very acute symptoms through their COVID illness. 7 members had 4 visits. Of that, most of them were a combination of preventative care visits and problem-based visits. So they come in for like their annual exam and perhaps some lab screening, but then maybe got sick or had an acute care thing that we found during one of those visits they needed some follow-up care up on. And 113 members had 2 to 3 visits. Our most common visit, as usual, was the established patient visit, and just a reminder that visit could be for anything from a medication refill to the flu. That just means that they're a regular patient within the clinics, and they're coming in for some sort of care that is either acute or a follow-up visit. 51 of those visits were for annual care, and then 40 of those visits were dietitian visits. 139 were telehealth virtual visits, so that was quite a good number to have that full virtual visual care as well as audio with that type of telehealth. Mondays were the busiest days of the month of January. The clinics were closed on New Year's Day, Friday the 1st. All 3 of the centers were closed. Mondays and Thursdays seem to be traditionally within the clinics our busiest days is what we're seeing. With our virtual appointments, we had 161 virtual appointments in the month of January. Stewart's Creek and Walter Hill remain with the highest average of virtual utilization for their appointments. For New Salem, they had 36 virtual visits, accounting for about a little over 14% of their visit care. Stewart's Creek had 43 virtual visits, with about 25% of their visits being virtual, and Walter Hill had 82 virtual visits, with just over 40% of their visits being virtual. With that, only 33.5% or so in the month of January were need-based to be virtual, meaning that their symptoms would keep them out of the clinic for everyone's safety, and over 66% of the visits were by choice of the member that they found that to be a more convenient option for them to receive care. Referrals by specialty, we had 102 referrals in the health centers in the month of January, 32 at New Salem, 50 at Stewart's Creek, and 20 at Walter Hill. Our dietitian remains to be overwhelmingly our largest source of referral by specialty, with 32 referrals in the month of January. Next to that, with sleep medicine and dermatology, each with 9 referrals, and then gastroenterology with 8 referrals. In our financials, we had 441 total unique members in the month of January, a total operating cost of $169,235.67 for a PEPM of $26. Our top 10 diagnosis codes are listed here for the month of January, but I was excited to see that in the month of January, our very large group there was for the encounter for the general medical exam, which is that annual physical, that preventative care, at over 22% of our visits for the month of January, so that was pretty exciting. Second to that, and not even close to the total, was type 2 diabetes without complications. And not too far down the list, there is an encounter for immunization, so yet another preventative care in that top 5. So we love to see that preventative care being right up there at the top of our most utilized services. In January, 69% of the members seen were female. The age range of 40 to 49 of the male member population and the age range of 50 to 59 of the female population were the highest population seen during the month of January. And again, this is just that month. It's not indicative of the clinics as a whole and what we see long term. In January, the female member population highest percent of BMI was in the overweight range of 25 to 29.9. And in January, the male member population highest percent of BMI was 30 to 34.9, which is in that obese class 1. And again, that is why our highest referral is to that dietitian service. And that concludes my presentation. Are there any questions?
Thank you, Ms. O'Neill. Are there any questions for Director O'Neill? Any questions? A good report. Thank you so much. Next, we have item number 6, Cigna COVID-19 presentation. Mr. Huffman. Paul?
Good afternoon.
Yes, sir. Good afternoon.
Paul Huffman. Can you hear me?
Yeah, you shaved.
Yeah, shave, let the hair grow. Yeah. I'm going to share my screen. All right. Let me know when you can.
We've got you.
See my Excel spreadsheet. Okay.
Yes, sir. We got it.
Excellent. All right, what I wanted to walk through, what Mr. Elam asked me to kind of walk through was just a brief overview of the COVID-19 claim experience for Rutherford County specifically. And if you look at this spreadsheet, what I've got 2 spreadsheets. One, and this is in your file share documents as well. So this document starts with the January 2020 through December 2020 entire calendar year COVID experience. Looking at the financial overview, so you've got a population of about 13,000 total members on the plan. And during the 12-month calendar year, we had about 4,000 individuals that were tested for COVID. Now, keep in mind, this is COVID tests that we know about. In other words, these are COVID tests that individuals received from a provider within our network or outside our network, and a claim was submitted to Cigna on behalf of that test. So this would not include the tests that are being conducted through the public health system, things of that nature. So you're probably going to see quite a bit more from that. Moving down, during the year, we had about 526 individuals that were diagnosed with COVID. And of those individuals, what the plan spent, so what Rutherford County spent on testing and treatment is in the next two boxes. So, as you know, testing and treatment was determined to be covered at 100% for all members during 2020. So Rutherford County spent approximately $457,000 on the testing during the year, and approximately $173,000 in treatment during the year on those individuals that were diagnosed with COVID. The next section down where it says member spend right here, you can kind of ignore this section because these are technically zero. The members did not have to spend anything on testing or treatment during the year. These represent some claim fallout that we've seen in our claim system where providers have either incorrectly coded a claim to send to us with member a different diagnosis and such. So those are essentially zero, and we're still cleaning up a lot of those claims from last year. The next section down, if you look, really refers to the total amount of dollars spent on all individuals who had a COVID diagnosis. So like we showed you up here, you spent approximately $620,000 or $630,000 on COVID alone. However, those individuals who had a COVID diagnosis had other conditions. Some of them had chronic heart disease, asthma, COPD, diabetes, things of that nature. COVID may have exacerbated those conditions, and those individuals with a COVID diagnosis ended up spending about $1.8 million in total. Again, $630,000 of that is strictly COVID related. The other $1.2 million is just on comorbid conditions associated with those same individuals.
So
as we move down,
Paul,
yes, sir.
How do you determine that? How do you scrub that data to reflect strictly COVID-related 19? Because we had been hearing that if you even just died of a heart attack, some hospitals were putting it down or being told to put it down as COVID-related. How are you making that determination?
For our purposes and for this report, it's just pretty simple. So if we receive a claim, and regardless of what that claim is for, if it's for a test, a treatment, a surgery, or a asthma treatment, if the doctor or provider, hospital facility tells us that individual had a COVID diagnosis associated, then they're going to fall into this $1.8 million. If we receive a claim and the only thing it has to do with, if the claim is strictly a test, COVID test, or strictly COVID treatment just of the COVID condition, the administration of that, then it's only going to fall into the $628,000.
Okay, thank you. Sorry to interrupt.
You're welcome.
Mr.
No problem.
Question before we get too much further.
I'm sorry, got a question from someone?
I do. This is Mary.
Mary, go ahead.
Hey, the total number of individuals tested, is that per person, or does that show up any multiple tests? Is that strictly like per person and they could have tested 5 times?
Good question. I believe that is unique individuals, so not multiplied if they receive multiple tests.
Okay, thank you.
You're welcome. The rest of this report goes into the details of how those individuals with COVID break out as far as their age range, gender range, whether or not they are employee, spouse, or dependent. I won't go into the details on that report since you can take a look at that and kind of break that out based on what you desire to see. It goes into whether it's inpatient, outpatient, professional services, and such. The other thing I wanted to point out is I'm going to pull the 2021 report. So, okay. All right, so now we're looking at January 2021. So this is literally just 1 month of data in January for COVID, and we'll start to carry this report out for the upcoming months, and I'll share that with Mr. Elam and you as needed. But it's interesting. So even in just 1 month, we had over 1,000 people tested, and 261 of those were diagnosed. So after the holidays, November, December holidays, we saw a large uptick in COVID, and so January was a really bad month, as you know, and you're seeing almost half of your total, or 50% of what you saw last year being diagnosed in the whole year of 2020 being diagnosed in January of 2021. The good news is you're still not seeing a lot of cost for this. You're still only seeing $72,000 in January for testing, $61,000 for treatment. Again, it's still 100% coverage for the member. And then of those individuals, those 261 individuals who were diagnosed with COVID, you have only spent about $340,000 on those individuals in total cost, including COVID and all other conditions that they had. So I think it's a good report to kind of take a look at on a monthly basis. We anticipate February to be a little bit better because we know we saw some improvements in our total, COVID rates during February. But I just wanted to give you the cost overall because I know that question kind of comes up a lot. Any questions on these two reports or anything else you want to look at it more in depth?
Paul, I've got one more question, not pertaining to these reports, but a week ago Monday, I fell into the category because we dropped here in Rutherford County the age limit down to 65, so that put me in the category to get my vaccine. And was able to get in at St. Thomas. I know if we go through State Farm, the county people will drive through and it's paid for by the state. Me and other commissioners who were asked if we wanted to come who qualified by age to go to St. Thomas, when we went, they asked for a driver's license and our hospitalization major medical card. So I'm sure they're billing my Cigna plan. They're not doing it for free. So, but my question is every Walmart, CVS, Walgreens, all those that have been identified by the state to start administering the vaccine, are they all charging the same amount back to the major medical plan?
Yeah, it's a good question. They are. CMS set the rates for what we are able to reimburse for the administration of the vaccine. So as you stated, the vaccine cost itself is being covered by the federal government. So any provider that receives a supply of the vaccine and then administers the vaccine, they're getting reimbursed for the cost of that vaccine from the federal government. They can then bill Cigna for the administration of the vaccine. And the first dose, we're reimbursing on average about, I think it's $17 and some change, or $16 and some change. That's for the first dose. The second dose that individuals receive, we reimburse $28. So we will see that as a cost as we vaccinate people, but the cost is still relatively small. And that vaccine will always be considered a preventive care benefit. So it will always be considered 100% benefit to the employee and the member.
But even as we get into the bulk, we are really just now beginning to get into it, but the bulk of our employees, once it gets down in the 35, 40-year-old range, et cetera, will be vaccinating, and you multiply that times 2, so you're looking at 17 and 28. You still don't think that it's going to be a significant number by the time we get everybody vaccinated. Right.
Correct. I don't think so, and I think obviously the benefit of getting it done far outweighs the cost, because it will be less than any of the money you've spent on those that were diagnosed with COVID to begin with. So it is a cost to consider. It's a known cost, but again, it is preventive cost that will prevent higher costs of having the diagnosis.
Okay.
We're getting into our projections next, and one thing our actuaries are saying that could be a question back is we're assuming 60% of the population will get vaccinated over the next 12 months. And so that would be a question. We were kind of curious, especially with the teachers, if that's something, some of our school systems are taking different stances on how they want to propose that. But at the moment, we're assuming 60% of the population will be vaccinated over the course of.
And if you recall, back last summer, we were projecting just the opposite of that. We were going only 40% because we polled internally our own employees in the county at different offices. So we were picking up around 40% said they were willing to get the vaccine, 60% didn't. And now I think it's just reverse to that. People feel more comfortable and seeing that that people are getting it, not getting severely sick, and et cetera, and so that's good. That's good. Okay. Anything else for Mr. Huffman? Does that conclude your report, Mr. Huffman?
Mr. Chairman, this is Commissioner Allen. I have a question.
Commissioner Allen for Mr. Huffman.
Thank you. Paul, I see that you've broken down the occurrence of diagnosis by age band. Do we ever look at the spending by age bands? I think it'd be interesting to know how much you'll be spending. Like when you get sick as a 17-year-old versus when you get sick as a 50-year-old, how is that spending breaking down? Have you looked at that?
Yeah, we probably have the ability to go that far. This report does not provide that information, as you saw. And I think the reason they developed the report that way, not all clients are as large as you, and some of the reports when we give to these smaller clients, when we identify an age range, we don't want them to be able to back into who the individuals are, so it's kind of a protected health information safety measure, but it's a good question, and I'll take that back and see if I can, if they can break that out into the cost by age range.
Here's part of the reason that and this may not carry weight with anybody, I don't know, but part of the reason that I was asking is I know there's still some vaccine hesitancy, and so everybody thinks it's going to happen to somebody else and not them. And so, I don't know, I just thought if we could see how much we're spending by age bracket, even you could say, this is serious. This is going to affect somebody your age. And so I'm just wondering if it might motivate someone to get the vaccine who may otherwise be hesitant.
Right. Okay.
And then, Mr. Chairman, the other question that I had that's kind of along the same lines, I don't know that it's for Paul, but I'm just curious, have we as a county developed any kind of a strategy with our employees to make sure that we are making the vaccine available as soon as possible to first responders, to teachers? What are we doing as an employer to try to expedite getting vaccines to that population?
Well, what I know right now, and you may have some comments, and we have gone through the majority of our first responders. We thought that we had gone through all of our 70 plus until Monday of this week, and then all of a sudden we get a list of 70-year-olds. There were over 2,000 on the list that came in from the state and told us, here's your list of 70, and we were already down to 65. So it's really frustrating for Miss Dixon, LaShannon Dixon, and so yesterday we chose, I announced on WGNS that we are moving forward with our own website. It's COVID-19RC for Rutherford County.com. And we're asking people to, and the telephone number, I don't have that with me, asking people to start going on the reservation website that our IT department has developed. We have a phone bank that's been working very successfully over in the jury selection room at the Judicial Building, all run by volunteers from the different departments. It's very smooth. The people are enjoying it because they actually get to talk to a person. And so yesterday when we kind of softly launched this, is that we're asking people, not by age group, it doesn't matter what age you are, just go ahead and go online, get an appointment, and we will or sign up and get a reservation, and we will call you or text you when your time becomes available. So the Sign Up Genius was not working. The state has already launched their second proprietary software program, and it's more laborious than Sign Up Genius was. The 3 more steps that you have to go through, and people are getting very, very frustrated. When they sign up there with the state, then they're calling our health department and wanting to know they misplaced their card, they forgot what date they're supposed to come in, and our health department can't get in to view the state program to see when their appointment is. So that's why we're determining our own destiny right now. And so as of yesterday, started taking teachers this week. We went 65 and below, or 65 and above, and then dropped it down from 70 to 65. We're gradually moving into it. We really didn't make it an announcement for the school teachers, but for those on the school board, that they will all talk, and so everybody knows that we can go. We're doing teachers. St. Thomas is, I think, doing teachers as well. They're going to take upstairs on the 8th floor, and downstairs they're going to start taking teachers as well. And they've opened up Walmart out on Joe B. Jackson Highway, I think Las Casas drugstore. There's numerous that have come online, and I'm going to try to see the governor. He's coming in town tomorrow to put an emphasis on let us determine our own destiny, cut us loose, let us take care of our citizens. You worry about Shelby County. As came out today, they misplaced or let 2,500 vaccines expire, and they had 30,000 in reserve for whatever reason, so the state and the governor decided to take over Shelby County because of that. We have a good system. Our software system's working. Our IT department's done an excellent job. So we'll be rolling out and getting that information out through our PIOs and trying to encourage when it's time, but just have everybody, we'll get that out to you, Commissioner Allen, and all the other commissioners to help us get the word out to go in on our software system and sign up. And the end goal is to get as many shots in people's arms as quickly as possible, as long as we got the vaccines coming in. But when the state, they move the goalpost 2 or 3 times a week, and it's hard to follow what they're doing, so it's very frustrating. Just like the 2,000 that came in to us Monday, and now we got to go back and start calling 2,000 people trying to get them into the system. And I don't know why they were holding them, but they can't explain why they had the list that were 3 weeks old for the 70-year-olds. So that doesn't really answer your question as far as a clear strategy of what we're doing. It's been chaos up to this point, but I think we're getting it refined. And once we get the word out, then things are going to be much smoother when we hit the bulk of our number of shots that we have to start giving to the bulk of our population under our program.
Your comments they led me exactly to where I was thinking, and that is, we actually have 2 hats that we need to wear. One is, of course, the hat where you're trying to vaccinate all citizens, and then we have the hat as an employer. And so that was kind of the thing I was just wondering from an employer side, and I don't know what all the regulations and guidance and restrictions are that are placed on the vaccines, but that was kind of my thinking was if we have the opportunity as an employer to take charge of our own destiny and make sure that we get our teachers and our first responders and all those folks vaccinated, regardless of age, I just want to make sure that we're striving to do that everybody who wants a vaccine is getting a vaccine
that is
from an employer standpoint. but again, like I said, I don't know what your struggles are and what the restrictions are that the state puts on you. I don't know how much latitude you have in that, but if we have latitude, I'd love for us to try to come up with a comprehensive strategy to just focus on getting employees who want to be vaccinated.
That is our goal. Yes, ma'am.
Thank you. Thanks.
Any other questions for Mr. Huffman?
Mr. Chairman,
Yes, ma'am.
this is Mary. It's not really for Paul, but if you don't mind, could you tell us that website again that you just spoke of, the COVID-19?
IT just set that up yesterday. It's COVID-19, no space, COVID-19 RC for Rutherford County.com. And I'm sorry, I don't have that telephone number with me. I meant to put that into my phone, but you can call the office, and Rachel and Laura have that on their desk, and we're going to be sending that out to all the county commissioners so they can start sending that out. Ashley will be getting it out to all the PIOs in the respective cities as well, so they can help us get that word out. So I think by nothing else, we're going to start taking care of our own destiny. Okay.
Thank you.
All right.
Mr. Chairman, this is Jeff Phillips.
Yes, sir.
I think that number is 615-898-7997.
That is it. Yes, sir. Thank you, Commissioner. Did everybody get that number? You want to repeat it one more time, Jeff?
Sure. It's this COVID call center, and the number is 615-898-7997.
Thank you, sir. All right. Anything else for Mr. Huffman? Hearing none. Thank you, Mr. Huffman. Take us to item number 7, dental vision dependent eligibility for age 19 up to age 26. Ms. Griffey going to be making this report.
Well,
whichever one.
What I'd like to start off with here is that as we prepare for the rates and determine what the rates may be, we are looking at all different options and all different areas that affect the rates. One of the things we looked at was on the dental vision dependent eligibility age 19 up to age 26. At this time, this is an employee fully funded plan, no contribution by the county. But on this plan, the regulation that is, or the eligibility, one of the eligibilities is they must be
unmarried,
they must be unmarried, but one of them is that a full-time student. And that's one of them. And it also, it's only up to the age of 25 in the present eligibility part of it. So Melissa's got some numbers here. I've talked to Paul, I've talked to Mercer, like the state and other surrounding areas and their people are doing. ACA, when it came out, I wasn't here at that time, but when it came out, they changed this to where dependents can be on the plan up to the age of 26. But the dental and vision, for us eligibility, it did not change. So this is one of the things we wanted to look at to maybe let it mirror this is not a plan change, it's an eligibility change where it mirrored the medical plan, and to see what an impact it would have on the dental and vision.
So, as Mr. Elam said, back in 2012, 2013, if some of you may remember this, we, because of the Affordable Care Act, all applicable large employees had to remove the full-time status from the medical plan. That was mandated by the government. We had the option whether or not we wanted to followed that same ruling with our dental and vision plans, and we just did not present that to the committee at the time. So over the last few years, we've been managing this eligibility in our office. Every year, we go through a process where we verify that dependents that in this age category from age 19 up to 25 are still full-time students. We are responsible for gathering the information and having the employees provide that to us and tracking that. And from a system perspective, making sure that that feeds to Cigna via our eligibility file. What we're proposing is that for 2022, we remove that stipulation from our dental and vision plan. So our dental and vision plan will mimic what our health plan currently puts forth, which is allowing a dependent child, an eligible dependent child, to also remain on the dental and vision up to age 26, regardless of their student status, regardless if they're a full-time student or if they're an unmarried dependent. We are not asking to raise the orthodontia limit on the plans, which is set at 19. So the impact to the plan would be lessened because we are not asking to move that. We're only asking to allow those children that are already covered on the plan because they are a full-time student, but we're also asking for those that maybe didn't qualify to have the opportunity to stay enrolled past the age of 19 in the dental and vision plans. We're also asking that we move the age limit from 25 up to 26. Again, so this mimics the health plan. It's a little more manageable from a standpoint of in our office, but also for the employee to when they have a child that may need some dental work, sometimes that can carry over into medical also, and it kind of gives them a little avenue to have better coordination of benefits there if they're covered.
Mr. Chairman, also, I have, in my discussion with Paul and with Cigna, one of the comments that they made is that, you know, if your mouth is healthy, it helps the rest of your body. Yes. And this is where it ties into the medical part. If you have kids on a plan up to 26, that's one of the things we're looking at for the dental part. And let me kind of divide this slice of this pie up, and Mercer can speak to this a little bit more, is that the dental plan, vision plan is running good, and it's not, according to Paul, not going to be a big, it will not be, we'll not see an impact to raise rates at this time. The slice that we're talking about is if someone is an employee and they added somebody in this age bracket 19 to 26, they would go on the family rate at this time. So that's not going to affect the plan. If you have somebody that would age out at 25 and goes to 26 with the plan already paying for itself at the rates that they're at, that's not going to affect the plan. You just get premiums for a little bit longer. And Paul might want to speak to this, but this age group is not a high utilization where you have a lot of claims in this age group from 19 to 26. And then the plan is also, on the dental plan, is also capped out at $1,500, if I'm not mistaken.
Right. That's excluding the orthodontia.
Yeah. So it's you know, maximum spend is $1,500 on the plan itself.
Anyway.
Is this something we can already do, or do we need a motion?
This is something that I would like to receive. I would like to get a motion from the committee. And like I said, I think it's an additional benefit, but it's something that we won't, the projections are now that we will not see an increase in the dental or vision due to this change at the moment.
Okay.
And Paul, would you want to add anything to that?
That's correct. So when we looked at this and discussing it with our underwriters to say, okay, if Rutherford County were to amend their eligibility rule to allow anyone, they don't have to be a student, but anyone aged 19 to 26 to be eligible for the dental and vision, just like they are on the medical, they determined that the amount of enrollment that would arise from that opening and the utilization associated with those additional children is so small and insignificant that it would not impact the overall cost of either the dental or the vision plan.
All right, that being said, I'm looking for a motion to amend our benefit schedule.
This is Lois. I'll make the motion to change the benefit schedule to add the dependents up to age 26.
Okay, you've heard the motion.
I will second it.
Have a second from Shay?
Correct.
Okay, any other questions?
Could I ask a question, please, Mr. Chairman?
Yes, sir.
Mr. Phillips,
Commissioner?
is there eligibility requirements after you turn 19 up to 26? What if someone has other insurance options available to them?
Are you talking about if they're covered on another plan on the dental and vision?
No. The way I understood this conversation going is that someone, is there eligibility requirements? You said you're removing the student classification, right?
Oh, I think I understand what you're saying. Yes, sir. They do have to be an eligible dependent, and it would follow the same rules as the medical does, which means a legal dependent. So it would need to be a child, stepchild. Yes, we still do follow a dependent verification process to verify their eligibility. So that would still apply.
So if someone 25 years old was employed somewhere else and had insurance coverage available to them, they would not be eligible.
No, I think under federal law that as long as you're a student and going to school, is that you're covered up to 26? Is it?
Well, health reform.
Paul, help us out.
No, and these are the rules that Rutherford would apply. But where you're going with that question is no. There's no restriction on anyone up to age 26. That would be what you're looking at, and that's what's happening right now on the medical. So no restriction. No, if they are not a student, it's fine. If they're offered insurance through their employer, they can still be on your plan as a 26-year-old dependent, and that's what's being proposed for the dental and vision.
How can that be? How can Rutherford County, the taxpayers of Rutherford County, be responsible for paying someone's insurance that have insurance available to them someplace else? It makes no sense to me, and I'm just speaking off the cuff. This doesn't make any sense at all to me. You know, we do spousal, if your spouse has insurance covered someplace else, they have to enroll in it and pay some type of a dependent surcharge. But
yes, sir.
I'm just throwing this out there to me, and I'm looking at it from an employer perspective. Why would we do that? Why in the world would we do that? Pay for someone's insurance that is working full time, and would they be classified as a dependent at that time? I guess I'm just trying my best to figure out what we're doing here.
Mr. Phillips, under the Affordable Care Act, that's mandated by the government that our plan allow a dependent child regardless if they're employed, have benefits of their own, if they're unmarried or a student. Those stipulations were removed by the government when Affordable Care Act was passed back in 2012 and 2013. It doesn't apply to spouse. That's why we have the spousal exclusion on our plan, because the Health Reform Act did not cover spouses. It only protects children. So what we're asking, because it is employee funded, that we allow children to stay on the dental and vision with the same stipulations and same eligibility rules set forth by Rutherford County up to age 26.
Now, this is Mary. Like Melissa said, the dental and vision is strictly all totally funded by employees, and I'm speaking as that because I have both dental and vision, And so I'm paying for the plan completely. Rutherford County is not putting any premiums towards those. Now, as for the spouse carve out for the medical, that is what we as the committee did in full commission going forward on the spouse stipulation so that we could get ahead of the, I think it's the Gadsby number. I may be saying that wrong, but that was one of the stipulations where, we draw the line in the sand of how many years of service you had in 2010. We also, to help that huge number that was coming, we took the spouses off ourselves if they had medical available through their employer. That was nothing that was mandated by any federal government or any way. That was, if I'm understanding and remembering right, what we done to try to get a hold of future expenses for future retiree dollars. But the dental and vision is strictly all paid for by each individual employee.
That's correct.
Let me just, I understand what you guys are saying, and I'm not saying we're doing it wrong. Just to me, something about that doesn't sound right. We've got a 25-year-old who's living on their own someplace and still under our plan, working full-time. What if they're working full-time any place that provides a full set of benefits? We can still carry them under ours? That's what we're saying, right?
Yes, sir. That's correct.
That's correct.
That's what the government said we could do on the medical, that, but for Mr. Phillips, for myself, when my children got old enough and have jobs that have their own benefits, Mama said, it's your turn, you're off.
Mary, that's where my mind is leading me right now too, I just, for the life of me, I can't understand that we don't have the option to say, I don't care what the government says right now. I mean, a lot has changed in the last 8, 10, 12 years, but I just don't understand how one employer can be responsible for carrying benefits for another employer. And experience and all those kinds of things, I'm not 100% sure that it doesn't have some effect on us. And once again, I'm looking at this maybe not exactly the way you are, Mary, or anyone else. I'm looking at this from an employer perspective, or trying to, and it just, maybe my brain has got petrified through the years, but nothing that I ever went through in my 45 plus years as an employer, nothing along those lines adds up to anything. So, that I'm not saying that I'm not wouldn't support this. I will if you guys think that that's what we need to do, but it just doesn't make any sense. Paul, help me here, okay? If we're a private employer, does a private employer still have to carry those folks up till they're 26, even though they're working someplace else?
Yes.
Yes.
Really?
So yes, Commissioner, and remember to differentiate between medical and dental and vision. So medical, the ACA requires it. You don't have a choice. That was to cover all those 25 and 26-year-olds that were living on their parents' couches and didn't have health care. And Obamacare said, we're going to cover them, and you don't have a choice. So you accept that. You're not voting on that today. And then Ms. Hickerson, so Rutherford County wants to be able to administer the dental and vision in the same fashion and be consistent. And the good news is Rutherford County government is not having to pay for that anyway. So that's why it's all paid for by the member, and whether or not you agree with that then becomes a different issue.
You're right. It's all on me. It looks like I'm sorry. I didn't mean to bring this up, but to me, it just the way I was raised and the way managed. It just doesn't seem ethical. But I get it, you guys. I'm sorry. I'll shut up.
No, Commissioner, the one true statement that you made, things have changed over the last 8 or 10 years. Yep. They're a much different world than what you and I grew up in or even started on this county commission with, but it is what it is. So we do have a motion before us and a second. And any further discussion? Call the roll, Madam Clerk.
Rhonda Allen.
Yes.
Dr. Andrea Anthony.
Yes.
Doug Bodery.
Yes.
Amber Brown. Amber Brown. Shay Crowell.
Yes.
Holly Deering. Holly Deering. Alan Farley.
Yes.
Mary Hickerson.
Yes.
Lois Miller.
Yes.
Jeff Phillips.
Yes.
Shantae Sherrill.
Yes.
Eric Tutobeni. We're unanimous.
Motion passes. Thank you. Last item on the agenda today, members, is a report from Mercer. Mr. Brown, Mr. Davis is going to talk about our medical, dental, and vision discussions. This is kind of precursor before they come back with some hard number decisions we have to make next month. But we just wanted to let Mercer kind of plow the ground before we plant seed, okay?
Thank you, Mr. Mayor. So today we just wanted to kind of catch up to where we are, especially since earlier this month, the Budget and Commission did vote on this committee's recommendation for Cigna to be the medical, dental, vision, stop-loss, and prescription drug vendor for beginning in 2022 and for the next 3 years for the 2 one-year extensions. So that has been adopted by all committees. With that being said, the next kind of step we're going to have in March is to set and finalize the 2022 budget and projection. So we wanted to go ahead and outline where we are today. We will come with more numbers and details around these next month, but wanted to, like the mayor said, kind of plow the ground a little bit, give you food for thought, let you think on it over the next few weeks so we're not presenting it all at once. So Mr. Huffman presented the COVID-19 stats, and we found those very interesting. I saw those a couple weeks ago and found it interesting that in January, almost a fourth of the people tested happened in January versus the entire 2020 calendar year. So COVID is still a big issue, clearly. We just spent 5 or 10 minutes discussing the hotline. So as vaccines roll out, the COVID picture will change. As cases go down, the COVID picture will change. As of right now, actuaries are still saying you can expect a 2.5% claims increase due to COVID. So if nothing else changed, you would have a 2.5 claims impact on COVID alone. And again, in 2020, I believe we saw right at $1.8 million associated in cost with COVID members versus kind of what we're seeing testing-wise as well. So that being said, we are looking at, from a medical standpoint, we're going to call it our moderate projection of around 8.5% is what 2022, with no plan changes, no changes whatsoever to plan designs or to anything that has to do with the deductibles, copays, anything like that, 8.5%. As a reminder, the plan now is for every 1% of increase, it's worth $780,000. So that 8.5% increase today, if that's what we had to settle on, would be about $6.6 million in increase for 2022 versus 2021, which is a lot of money. And we've had discussions. This is going to be a tight budget year. Again, that 8.5% does include some trend assumptions, some claims margin. There is the deductible plan and some migration that is happening from that grandfather deductible plan to other plans, and then, of course, COVID. So what we wanted to kind of outline today, with claims through January, we're looking at an 8.5% moderate increase. We will have claims through February when we present next month. With that 8.5% increase, though, we do want to go ahead and kind of outline some strategies we're thinking about, and that we've kind of had some discussions with Cigna and different entities around how to maybe mitigate that increase. And so we have talked in the past around local plus networks. Cigna's presented some things on that. We've discussed what a small network would entail. We've looked at, or talked about high deductible health plans. So, implementing a true high deductible health plan with an HSA component, maybe in addition to the HRA and the copay plans you have today. We've had good discussion around wellness and how to maybe kind of improve that. I think Mr. Chapa kind of shared some really good numbers. We are getting good traction with St. Thomas and the Salem Clinic, so there's a lot of good momentum there. So we're going to come back next month with 4 or 5 ideas that will allow us to bring the 8.5% increase down. But what I want to do is to let you know what that number is. In addition to that 8.5, Mr. Phillips, you'll be happy to know that we are projecting, even with what was just voted on, we are projecting dental and vision to be 0 for 2022. So really the discussion, the main points will be around the medical. So I'm going to stop there for a second. And I know, for point of reference, in the past, I think last year we ended up on a 7% increase. So again, 8.5% is somewhat in line with what we've had in the past, but we just know from the stakeholders here and the people we've talked to that from a budget standpoint, we cannot, we probably do not have the luxury of just accepting the $6.6 million increase. So again, that's going to be March when we show you mitigation strategies. But I wanted to pause and maybe open it up for discussions or questions that we can bring next meeting to help facilitate that discussion.
So, Mr. Davis, you think that with those strategies, you'll bring to us percentages or numbers of ideas, 3, 4, whatever they may be, that this committee can look at?
Right now, we're planning on probably 3 recommendations, different ones that are going to range from maybe 1 or 2% in what we're going to call buy downs to up to maybe 4 or 5% in buy downs, depending on how many people enroll in these options. And we are working with Cigna. Everything we roll out, we will have what that plan option is worth, and then kind of what enrollment we can expect based on other entities of your size and how we coordinate the enrollment, the premiums, and however we need to coordinate to get however many people we need in those plans. So we'll come with kind of both of those answers. Yes.
I have a question for Jake or J1. This Mary.
Mary.
I know I hate to be the one to have to say it, but we've been thinking about it, and it was brought up several years ago when we went and we grandfathered the deductible plan in and went strictly to only offering copay and HRA after the said date. Is one of the options you're looking at, because I know county commission set a line in the sand of if the numbers on the deductible plan drop below this, then it's not a viable plan and it needs to be done away with. Is that going to be one of the options that you bring to us to look at, or can we get research done to see if we've gotten to that point of the numbers are just lower and the cost to the employee is just, it's not a viable plan to offer anymore?
So that is a great question, and the answer is yes. We are going back into some of the older minutes to see exactly what that number was. I have heard people say 100, I've heard people say 200, I've heard people say 300, right? We're going to try to find what that exact number was. As of right now, in January, we have exactly 200 people enrolled in that plan. And I do believe by February with some, that is according to Cigna, when I look at our internal enrollment data, we're probably going to be under 200 come next month. Ironically enough, that plan, if we get rid of it, which administratively does make some sense, if we get rid of it from a budget impact, because that plan, the budgeted rates are quite a bit higher than the other 2 plans, if we get rid of it and move those, let's say 200 people into other plans, it actually hurts our increase. because the amount of money we save in claims, right, Mary? You know, they're going to have the same claims no matter which plan they're in. The rates that we're budgeting for that plan that is grandfathered, that is quite a bit higher, would actually raise our increase from 8.5 to somewhere in the 10, if not even a little more than that % range. So that's my response to the committee. We can absolutely choose to do what we want. In a year where budget is going to be so impactful, I am less inclined to recommend doing something that isn't going to help anyone or the budget, right? But that's the data we have today.
Jake, when you bring that, are you going to be able to have us, because I know for a fact, because there are some that I know that are on the plan, that the premium for them, of course, they pay for it because they have the higher premium, but is there a way to see what that cost would be? Because it just seems to me like it is starting to get almost too expensive for our employees as for what they're getting. I'm thinking of some that I really think that they're paying too much because they're not, thank the good Lord that they're healthy, not having to use the plan as much. But they're, like I used to be old school, don't make a change, deductible's the way to go, but eventually it got to where I couldn't afford it and I slipped to the copay plan. So is there a way of knowing, or can y'all get numbers? I mean, I get it that it's going to move us up to the 10% part, but I just hate seeing folks pay for something that is too much premium for actually, like I said, thank goodness that they're not having to use the plan. They're not getting their money's worth is what I should say.
We have a tool that's an out-of-pocket calculator, and it takes into account what you pay in your paycheck and then what you would meet towards a deductible and an out-of-pocket at certain thresholds of claims, just like you're talking about, Mary. We will run that. I agree with you. Without having run that calculator, I have a pretty good idea that financially, due to what's coming out of their paycheck versus the plan designs of the other two and the deductible, most people are not better off, honestly, being in the deductible plan. It's more of they're doing it because that's what they've always been. So we will have that, and again, we can have this discussion on whether it just makes sense to get rid of it or not. But we will bring that and show the hard data on what that looks like, okay?
Thank you.
You bet.
Other questions? Mr. Brown, Mr. Davis. Well, members, I think you've heard this discussion, but I'd like to emphasize that next month is kind of where the rubber will meet the road, and definitely we need 100% participation from this committee because this is a big step. As we kicked off our budget this year, I asked all of our constitutional officers and our department heads to, with this in mind, that we try to bring a flat budget to the county commission, which we have started. Ms. Nolan and I have been, every day we're going through, thank goodness, our smaller budgets right now. The big ones are still looming, but the small departments have kept it flat. It's the big ones that you know, the sheriff and the EMS and fire, all of those come in with large increases just because of the population is increasing and we have to provide those services as well. And then, of course, we have to anticipate growth with schools because so many new children are moving into the county as well, and we have to provide those services. But this is a big deal, is whether or not the county commission can even stomach a property tax increase or start making cuts. So this meeting next month is very, very important that I ask you to come, and we'll let Mercer make the presentation, and we'll try to make an informed decision before we send it on to the full commission and determine our final tax rate by the end of June. So here we go. Anything else to come before us today? Hearing none. Is there a motion to adjourn? Well, we're adjourned.